So we're going to move on to what we had here at ASH, which were, I think, two important updates on frontline therapy. First, the updates on the SWOG 777 trial, which I had the honor to present, the follow-up on that. And then I think what was quite exciting for everyone was the first results from the so-called the MAIA trial, the daratumumab Revdex versus Revdex, the full results of which will be presented as a late-breaking abstract tomorrow, actually. And so we just have what was in the abstract that we can give to you today. And then a small abstract that was presented about what is the impact of the presence of the 1114 translocation in the frontline setting. So if we go through the two trials first, the update on the SWOG trial, it included an update on all of the response evaluation as well as the endpoints of PFS and survival. And so I would draw your attention just to the percentages here so we can be thinking about the comparison of these numbers with what we're seeing in the MAIA trial. So you can see here about a 75% VGPR or better, overall response rate 90%, and then in the RD arm 53% and 78% there. Okay, so clearly a benefit for the VRD, and this is evident in the PFS numbers, the remission duration here, which the numbers, it's very interesting with 7 years of follow-up now, the numbers are very, very similar, 29 months for RD versus 41 months for the VRD. And then the overall survival, I think what is quite impressive with the VRD is we have still not reached the median in terms of overall survival for the VRD. 55% of these patients are still alive at 7 years. So really pretty impressive to see what is the impact of 6 months of early therapy. So I think that it's quite a strong proof of principle that early intervention, the fast response can have a prolonged impact. And so this is the impact of age, and so this study did include patients up to the age beyond 75, and you can see here that there was a benefit of the triple therapy, VRD versus RD, but you can see here the decrease in outcome with RD is particularly over the age of 75, but a clear benefit in each age group, and so I think that this is, again, if feasible, a support for the notion of using a triple therapy or some kind of a combination in the older patient. And so what about the late-breaking abstract? What about the impact of DARA, lenalidomide dex, DRD versus the lenalidomide dex? And so we had the privilege of hearing about that at our International Myeloma Working Group breakfast. To hear some details, and so the results are really quite promising, showing an improved progression-free survival with the 3-drug combination, the daratumumab Revdex versus the Revdex. I would also draw your attention, though, to the median PFS with RD, 31.9 months in this trial, so it's helpful to make note of that. And then for the comparisons, I think it's also interesting to see here VGP are better. You can see here 79%, so actually very similar to the VRD, and then also quite similar to the RD, 53%, which is very similar to what we saw in the SWOG trial, actually. So very, very interesting to see that. And Mary V, you'll be interested in the last comment there. I think that your trial with the DARA VMP plus this trial clearly support the notion of the value of daratumumab in the frontline setting. Now, an interesting kind of a sidelight was a study coming from the Emory team where they studied over 1,000 patients with VRD, where they drew attention to the fact that in their experience, patients with the 1114 didn't do quite as well. So we tend to think of that as a favorable group, but maybe it's more intermediate risk than we had been thinking. And so I've put together some questions for our illustrious team here. What do we see for the future of Frontline? And I think that the fact that I'm using all of these bullets suggests that we're not entirely sure. But I don't know who would like to go first in selecting the quadruplets, the triplets, or what you might think the future holds for frontline therapy. Do you want to go first, Marie-V?
Well, I think that the situation is actually challenging because so we have a lot of new combinations, 3 drug-based combination, maybe in the future 4 drug-based combination, so with clearly very attractive results. So I think that your VRD study, the update of the SWOG study, showed the consolidated results with VRD. And the median follow-up is very long. And I think that this is an important thing for all studies, because now we are observing more and more very interesting trials, but with a median follow-up very short.
Yes.
We need to evaluate the trials with longer follow-up. So I think that there is not any doubt about the role of VRD as the standard of care in newly diagnosed myeloma patients, both transplant and non-transplant eligible, because in your study, so you have analyzed and presented during this Congress the sub-analysis according to the age, and I think that the results with a longer follow-up confirm the benefit of VRD followed by RD in terms of both progression-free survival and overall survival. And so we are going to have a VRD, and we are going to evaluate if the addition of daratumumab is going to result into a significant benefit. That the answer is maybe yes, and so phase 3 randomized trial are going to start in order to answer to this question.
Right.
In the meantime, so we can potentially add daratumumab to, I would say, 2 standards of care. VMP, that I know that it is not a very commonly used here in the US, but so it's a standard of care in Europe and in other countries in which so the affordability for Lendesi so is not available and is not clear.
And the added benefit was quite clear.
Yeah, and so it is possible to add data to VMP, and also the Alcyon study has been updated during this Congress, and with 1 year of additional follow-up, again, I think that the benefit in terms of progression-free survival is confirmed, and in fact, so for me, it's interesting to see how when patients receive DARA single agent as maintenance, so the PFS is sustained and really few patients progressed and are dead. But of course, so we are going to hear tomorrow early in the morning the late-breaking abstract based on Lendex plus DARA. And I think that the results are impressive, but impressive if we start by the control arm, because the median progression-free survival is 32 months, so longer than expected if we consider the first study or the control arm in the SWOG study.
Right.
The hazard ratio is so it's very low, and so we can expect a median progression-free survival of approximately maybe 5 years in the upfront setting for elderly patients with newly diagnosed myeloma. So I think that we are going to have a new standards of care. Today, I think that I would like to confirm that VRD is a standard of care that we can use. In the future, maybe KRD, and I know that here in the US, KRD is sometimes used for patients with high risk. And so there are some trials, some randomized trials currently ongoing that are going to compare VRD with KRD.
Yes, the endurance is going on.
Exactly.
Yes. So what do you think, Joe?
Yeah, no, I agree very much with Marie-V. I mean, I think I would look at it as a stepwise, as you've said. In the short term, it's confirming the use of monoclonal antibodies up front. It confirms triplets are still the standard of care. I don't think we're quite yet ready to suggest a quadruplet. I sort of look at it because this is so similar to your SWOG study, Brian, and the depth of response. I completely agree with Marie-V. We need time, but it's a little unlikely that we're going to see a massive difference over time. So I try to think of it simplistically and say, well, we have proteasome inhibitors, immunomodulatory drugs, and monoclonal antibodies as the 3 novel parts of what we use, along obviously with steroids and sometimes with melphalan. And now I think we have legitimate grounds to say It could be VRD, where you take a proteasome inhibitor and IMiD, but it could also be a monoclonal antibody and IMiD. And
or
as we know, the
DVD.
studies are going. It sort of feels like Castor and Pollux in the front line, right?
It is,
Where
yeah.
we like the
It basically
confusion,
is.
right? We want there to be choice. This is better for patients because
Yeah.
Right.
I can think immediately in my clinic of patients who I'm going to say, you know, the DRD regimen is really attractive, or maybe VRD is a little bit more attractive. One other comment, though, Brian, I think is important. When we do start looking in the longer term, one of the fundamental differences between this study and almost any other study that's been done in transplant-ineligible patients is that both novel drugs, as it were, the monoclonal antibody and the immunomodulatory drug, are continued indefinitely.
Yes,
So in your SWOG study, the bortezomib was stopped after about 8 cycles.
Of necessity, I mean,
necessity.
you have to stop it.
Right?
Yeah.
In your
In the
Alcyon
Alcyon
study,
study is the same.
AMP goes
thing.
for not really much more than a year. So this is one that may well have that long-term benefit by virtue of keeping patients on both of those, assuming it's feasible. And we learned from using in the relapse setting, that combination is feasible in the long run.
Right, and that ability to have the longer exposure is quite important to get the benefit, yes. So I don't know if you want to comment on the, we can maybe discuss later. Do you see possibly a role of venetoclax earlier in the disease? Obviously we've been studying it in the relapse setting, but do you think that there would be a possibility of more of a precision approach? Do you see any early use of venetoclax, or maybe not?
I think so.
Maybe?
So yeah, maybe we have right now the results of venetoclax single agent or in combination with dexamethasone in relapse and refractory myeloma patients, and so it's effective in patients with 11-14 translocation. I think that we are going to see maybe next year the results of the randomized study comparing VD versus venetoclax plus VD, in which so not only patients with a translocation 11-14 are going to be included, and so I think that for me these results will be key in order to know if we can use venetoclax only in patients with 11-14 translocation or in a more wide population.
Broader
But anyway, I think that it represents the first option of targeted therapy. So, and according to the results that you have showed coming from the Emory in more than 1,000 patients, so I think that we consider the 11-14 translocation as a standard risk translocation, cytogenetic abnormality, and maybe it's not so standard, and it would be, I would say, intermediate risk cytogenetic abnormality, and so I think that why not, if we can target this cytogenetic abnormality with an oral drug like venetoclax, I think that we have to prove, of course, that the drug is working and the drug is safe, but so I see that could be used.
Could be an option, yes, yes. I think because of time we might need to cycle back and see about the potential role of CAR-T and BiTEs in the earlier disease, but probably a little bit early to be talking about that, but maybe something for the future.
Yeah.
Yes.
Absolutely.